presenter for today will be Melissa Jones from Geriatric Programmatic. She's a Geriatric Programmatic Nurse Specialist at UPMC Mercy. Before I turn over to our speaker, I wanted to give a general overview of the Livewell Allegheny initiative. Livewell Allegheny highlights the importance of increasing physical activity, healthy eating, and reducing smoking for all Allegheny County residents. By bringing awareness to these three modifiable behaviors, diet, physical fitness, and tobacco use, we hope to reduce the four top chronic diseases, diabetes, cancer, lung disease, and heart disease, and stroke, that can be positively impacted by behavior change. We believe that through collective action, we can make Allegheny County a healthier place and ultimately the healthiest county in the nation. Livewell participants range from communities, schools, workplaces, and restaurants. I'm sure we have a mix of partners in this space. Livewell Allegheny also has various partners throughout the county to help support the community in health, safety, and wellness resources. To view the resources, please go to our website at livewellallegheny.com/search-local-resources. And for more information and to join the initiative, please go to our website, www.livewellallegheny.com. And now, without further ado, I'll pass the presentation over to Melissa.
Thank you so much, Melody. I appreciate the opportunity to share a little bit about what Mercy is doing as far as becoming an age-friendly health system and how we can really help Allegheny and the project and our residents live well and age well. So I'm just going to turn my camera off just to save some bandwidth and share my screen here. All right, can everyone see that okay?
I can see it, yes.
You can see, okay, yes. Perfect. So as Melanie said, we're going to talk about age-friendly health systems and what's called the 4 M's. So what we're going to do is we're going to define what an age-friendly health system is. This may be some new terminology to folks. We'll identify the 4 M's of an age-friendly health system and talk a little bit about what Mercy is doing to support those 4 M's. And if you have questions, you can feel free to put them in the chat, or we'll have some time at the end of the presentation for discussion as well. So actually, the World Health Organization started with defining age-friendly. And what they say is that an age-friendly environment fosters a healthy and active aging. And it enables older people to age safely in a place that's right for them, free from poverty, continue to develop personally, and to contribute to their communities while retaining autonomy, health, and dignity. And because older people know what's best that they need, they are at the center of any effort to create a more age-friendly world. So
I hate to interrupt you, but just really quick, if you have your mic on, can you please turn your mic off because it can be disruptive? Thank you so much. Right. I'm so sorry. Please go on.
No worries. No worries. So, you know, with the World Health Organization really gave us more of a broad definition of age-friendly. And from that, we've got several movements. One is the Age-Friendly Health System Initiative. That is an initiative of the John H. Hartford Foundation, the Institute for Healthcare Improvement, the American Hospital Association, and the Catholic Health Association of the United States. So these groups really saw the importance of health systems being age-friendly and supporting our older adults. And age-friendly health systems really aim to follow a set of evidence-based practice. Their idea is to cause no harm, and they really want to align with what matters, which is actually part of the 4 M's, to the older adult, their family, and caregivers. So it's a very person-centered approach to providing care for our older adults. A little bit more about the John H. Hartford Foundation. They were actually formed in 1929, and they came out of the A&P grocery chain. And much of their work is dedicated to improving the care of older adults. And you can see here their 3 priority areas, one being age-friendly health systems, family and caregiver support, and also looking at end-of-life and serious illness. And so a lot of documentation, a lot of other programs have kind of spurred from the efforts of the John H. Hartford Foundation. And so you might ask, why an age-friendly health system? What does this mean? So important for us to understand is the demographics of our older adults. And by the year 2035, which I feel like, wow, that doesn't seem so far away anymore, the people over 65 will actually outnumber people under 18. So it'll be a pivotal time in history. Also, we know that our older adults are very complex. As we age, we, certainly look at aging well, but unfortunately, we see that about 80% of older adults have one chronic condition, and even about 77% have more than 2 chronic conditions. And sometimes our older adults, we see that, we have higher rates of long-term care and also skilled nursing use. And the one lesson that we learned, it was a hard lesson from COVID, is that there's a disappropriate harm for our older adults. Thinking about the biology of aging and, a compromised immune system, we do see our older adults hit harder by things such as COVID, the flu, and etc. So the 4 M's of the age-friendly framework focus care on 4 main priority areas: what matters, mobility, medication, and mentation. And really what this initiative teaches us is that it's not just a program. It's not just kind of a thing that, is the thing to do at the moment. It's really about a shift in care, and thinking, kind of taking care out of those silos that we often see, making care more interdisciplinary and more synergistic. So the 4 M's of the age-friendly framework, as I mentioned before, one is what matters, and this is knowing and aligning care with each older adult's specific health goals. And it's much more than what their end-of-life goals are or their advanced directives. It's really getting to know what is most important to that person at that particular time. Medication, so we look at medications being age friendly. So if medications are needed for a particular illness or a chronic disease, that we look at medications that have been proven to be safe in our older adults and do not interfere with what matters, so what's most important to them, do not impact their mentation or their mobility. Mentation is another part of the 4 M's. And this focuses on preventing, identifying, and treating, managing dementia, depression, and delirium across all care settings. And for us, in particular, in the acute care setting in the hospital, we focus on managing and preventing delirium. Mobility, and this is so important because it really impacts our overall wellness. One of the things that we focus on with mobility as part of the 4 M's framework is safety. And so we not just only look at preventing falls, but we also look at encouraging mobility and, in fact, early mobility. And that really engages the individual to help them do what matters most to them. So you can kind of see that theme that all of the 4 M's really work together, and that they're really a pillar of providing age-friendly care. So let's focus on each of those 4 M's. So what matters most? What matters most is really the foundation for the care, and it shapes the care that's to be provided. It's really that driver of what's most important to that individual. It really helps to integrate care decision-making across settings. And it is not just limited, like I said earlier, to end-of-life planning. You know, a lot of times we have those conversations as we discuss things with older adults about their care, but this is much more, a little deeper than their end-of-life care planning. It also should be understood and identified and also documented across the health care settings so that it follows the person throughout the healthcare continuum. And one of the things that we know, we talk about age-friendly framework and the ability to apply evidence. Well, what matters is the least developed of the 4Ms because it's very subjective. It's person-centered. It's what's most important to that individual. And oftentimes we don't have the evidence because it's so subjective and so personalized. So, you know, one of the things that I like to think about in conversations with older adults is I reflect upon what matters most to me, and it helps me think about, you know, what might matter most to them. So I ask you for a moment just to kind of pause and think about what matters most to you. So maybe it's family, maybe it's a beloved pet, maybe it's a upcoming vacation. Perhaps it's a special celebration. Or maybe it's just getting to relax and sit and watch some television, right? Or a good movie. Maybe it's just having more time in your day or more time in general. And for our older adults, you know, sometimes we hear things like, I just want to be able to dance at my granddaughter's wedding, or I just want to be able to get back out and to my garden. So, you know, again, very personalized based upon what matters most to them. The one thing that we have to think about when we're asking the questions around what matters most is that we have to think about cognition. So our older adults with cognitive impairment or dementia, they're often very capable of expressing their goals and preferences. Sometimes we need to be very direct when we ask that question. Sometimes we can get the answers from families or caregivers. And sometimes we need to time those conversations. Maybe this person is more alert in the morning than they are in the evening, or more engaged in conversation in the daytime. So we, really think thoughtfully about how we time those conversations. Also, what matters can depend upon the individual's health status. So their goals and preferences may change over time as their health status changes. And what matters conversations may vary, again, based upon where they are with their health. So at Mercy, we've really looked at what one question could we ask that gets to the core of what matters most to the individual. And so we've started to ask our older adults, what are your most important goals as you look towards your recovery? And the one thing that we found is that we thought that this question, should be asked of all of our patients, not just our older adults, because it is so important to driving the whole team in planning care. Some of our program highlights, and these were led by our discharge planning team, is that they were able to really provide comprehensive and specialized hospital and outpatient services across that care continuum. They developed a discharge when process that helped connect our patients with other resources. So our older adults might engage in other programs such as a living at home program or the life programs that are throughout Pennsylvania, even respite care programs for some family members. And that 4Ms also has been part of the patient's whiteboard. So patients have kind of a communication board that's in their rooms, and what matters most has been written on that whiteboard so that all members of the care team know what's most important to this individual. Medication. So led by our pharmacy team, we have started to screen home and current medications when our patients come to us who are over 65. The criteria that's used comes from what's called the beers list. And no, it's not a list of all of the fancy beers that are out there. It is a list of potentially inappropriate medications for older adults. And so it might be like insomnia medications or even medications that may seem harmless over the counter, like Benadryl, but Benadryl can be very harmful for our older adults. We make some recommendations to either deprescribe these medications or help the prescriber find a substitute. Sometimes there's not a safe substitute for a medication that's on the beers list, and oftentimes non-pharmacological approaches suit the patient best. So for example, if a patient is having a hard time with sleep, rather than choosing a sleep medication that we know could be harmful in the sense that it could increase the individual's risk for falling, or it could decrease their cognitive ability. It could also pose a risk for delirium in this individual. We might make some recommendations around what's called sleep hygiene. So things like limiting screen time before bed, making the room dark and cooler, ensuring comfort, ensuring that all of the needs are met before the individual goes to bed for the evening. So things like that. So non-pharmalogic approaches. So some of the things that we found with implementing the 4Ms and medication is that we've used this with our transitions of care pharmacists. So certainly when patients are being discharged to perhaps even a long-term care facility, we can have those discussions about what medications are at high risk for any additional problems for the individual, and then also have talked to providers about deprescribing or alternative medications to the high-risk meds. Mentation. So as I mentioned earlier, mentation focuses on dementia, delirium, and depression. For us in the acute care setting, what we really hone in on is delirium identification, prevention, and management. And so delirium is a sudden and acute change in the individual's mental status. They can be inattentive, they can be hyperactive, or they can be hypoactive. And so we've done some training with our staff to be able to identify some of the differences to be alert for with their patients who may be at risk for delirium. There's various screening tools out there, and we've also worked with staff to think through some prevention strategies. And the interesting thing with delirium is that you prevent it the same way you manage it. So kind of getting to the core of what underlying issues the individual might have. So dehydration is a risk factor for delirium. So we really work on keeping our older adults hydrated. Engaging in activities. So it's really important, especially for our patients with dementia, to have some daytime activity, to be engaged, whether it's in physical activity, so maybe like physical therapy, occupational therapy, or it can be in engaging in some board games or a card game, crafting, things like that. We really teach staff to focus on the underlying causes because delirium may be attributed to an infection. It could be attributed to a medical emergency. We also look at supporting mobility through encouraging early ambulation. So trying to get patients up and out of bed, especially for meals, is really important. And because the 4Ms is such a synergistic approach in providing care, we also look at any medications that can pose a risk to mentation. So some of the things that we've done have been very nurse-driven, inspired by some research that was done with Dr. Inouye and the HELP program. And what we've done is encouraged our nurses to use some screening tools to assess for confusion, and also thought of through some of the measures and nursing interventions that could help prevent delirium. Some of the things that I talked about earlier, keeping the patient hydrated, keeping the patient engaged during the day in activities, early ambulation, looking for those high-risk medications. And we actually were able to study a few years back, we were able to study some of our outcomes from a delirium initiative driven by nurses and found that patients actually had a decrease in their length of stay. And more of those patients were discharged home versus going to a skilled nursing facility. So we were really happy with those results. One of the things we've also started to provide, especially for our patients with dementia, knowing that patients with dementia have a higher risk for delirium while they're hospitalized, we've developed kind of a dementia activities box on the go. So these boxes or bags are created with things to keep our patients with dementia engaged. So word searches, bingo games, cards, even some stuffed animals to cuddle and comfort. A lot of times our patients with dementia are very anxious when they come here. Supporting mobility, I think, is very important. And again, integrating those 4Ms together, what we find is that being very proactive with ambulation. So, a lot of times I think the misconception is that people come to the hospital to get rest, and it's actually you come to the hospital for us to get you back to where you started. So there's various tools that we use to assess mobility. One of the tools there on admission is called the AMPAC, and it really looks at what your functional status is or was before you came to us. And so we try to get you back there. Also focuses on fall prevention, and Melanie and I were talking about a great program out in the community called Matter of Balance, and this focuses not just purely on fall prevention, but also some of our fears about falls. And one thing we know is that being afraid of falling is actually a risk factor for falling. We also focus on home safety, so really making sure that the home environment, kitchens, bathrooms, have a high rate of fall risk. So ensuring that grab bars and bathrooms are safety. Exercise. So exercise is really important as we get older. We start to find that balance and coordination changes, and that if we kind of maintain exercise and activities to help with balance and coordination, we can see a reduction in fall risk. And then oftentimes medications can pose a risk for falls. So you think about blood pressure medications, maybe the physician has had to change a dose, and the individual has some dizziness, and this can certainly pose a risk for falls. And then thinking about medications that, cause some side effects, and that can also be a risk factor for fall. So we take a good look at medications as well. Some of the things that we've done to promote mobility and ensure safety is that we've acquired lifts, sit-to-stand lifts, portable lifts, to really help get those patients who may be a little bit more difficult to get out of bed for staff, that we have these assistive devices. Certainly a variety of safety activities, and our education and quality teams have many collaborative efforts to provide fall prevention education to our staff. So when you think about implementing the 4Ms of age-friendly care, it's really the idea is to get this care out there for every older adult, every time, in every setting. And so we started with a pilot unit, and we were able to implement a lot of our 4M approach. Our goal is to spread this now hospital-wide, and it's certainly a big task thinking about a big hospital, but little by little we'll get there. The age-friendly health system from the Institute for Healthcare Improvement, they have various levels of participation. And so you begin as an age-friendly participant, where you basically define what the 4Ms practice will be for your hospital or for the practice, because age-friendly health systems are not just acute care hospitals like us at Mercy. It's also available for outpatient physician practices. So it's a very diverse movement. And then once you define what your set of 4Ms are for your healthcare system, you become a participant. You get kind of the logo and can start sharing that your team is very much dedicated to providing the 4Ms care of age-friendly. And then you start counting, as we did with our pilot unit, looking at the number of individuals over 65 who we actually provided that 4Ms care, and consistently each of those 4Ms being applied. So it was mobility, mentation, asking about what matters, and then focusing on medications as well. Once that has been accomplished, then you submit your information to the Institute for Healthcare Improvement. And if they decide to, which we were so lucky that they had, you are designated as committed to care excellence for older adults. And we're proud that we are one of the first within our UPMC health system to be designated as a committed to care excellence facility. So we're really proud of that. Now the work continues, where we continue to scale our work. So like I said, spreading that to other units at our hospital, and really being able to celebrate and being able to share that in platforms like this. So thank you again for that opportunity. The key actions to getting started are really describing your aims. How are you going to accomplish this? How are you going to deliver care that fits within that 4Ms framework? And so again, how are you going to determine what matters? How are you going to look at medications, mentation, and mobility for the patients that you serve? And then it's engaging a team, assessing your work, and developing screening opportunities for patients as well. So what we did is we took the experts of each of those 4Ms. So our pharmacy team led the medication reviews. Our quality improvement and rehab departments are on our subcommittee for mobility. We have our designated age-friendly unit, their representation, who has also been a great partner with Delirium activities, and they're leading our mentation arm. And then our care managers and social work teams are leading the efforts to get to the core of what matters most to our older adults. Then the ability to set frequency. So thinking about, how often are you going to perhaps screen for delirium, or how often are you going to look at medications? How often is mobility assessed? And how often is the opportunity there to ask the patient what matters most? Documentation, as we know, is so important. So putting that in the patient's medical record so that it then can be shared across all team members. Because we know certainly, nursing delivers a lot of care in the hospital, but also physical therapy is important. Pharmacy is important. So really getting all of those team members on the same page. And as I mentioned earlier, one of the things that I really like about the 4 M's of the age-friendly framework is that it brings all of those teams together, takes that care out of the silos, and really puts everybody on the same page that's driven by what matters most to that individual patient. And then the work is to act on. So, kind of describing what you want to do, what your age-friendly framework is, how you're going to implement those 4 M's, and then, implementing that hard work. And then finding champions and folks who take upon those responsibilities. So, certainly with our medication arm of the 4 M's, our clinical pharmacist has just been instrumental in being able to have discussions with our patients and their prescribers about medications that perhaps we can see a reduction in a dose, or maybe the medication was deprescribed altogether, and that everybody now is on the same page because perhaps this medication was interfering with what that individual found to be most important to them, or maybe it was interfering with their mobility or their medication or their mentation. So, very instrumental in that. And then our quality improvement team has been wonderful in helping us do some deep dives around falls and preventing falls. Unfortunately, we here at Mercy, we're a trauma center, and so we see, the pretty bad falls from our geriatric patients, and, kind of doing some retrospective review of how the individual fell at home, or, maybe crossing the street, things like that, and being able to work with them and implementing some safer strategies is really important. And then also with mentation, we know that delirium can keep an individual here longer in the hospital. And so working with our staff to recognize delirium, being able to distinguish delirium from dementia. So, many times for our older adults with dementia, they come to us very afraid and very anxious. And this is a new environment. So it creates a perfect opportunity, unfortunately, for delirium to occur. So our job is really to prevent it. And if it happens, being able to manage it effectively so that we can get our patients back to their home environment. And then, as I mentioned earlier, the core of really what drives the 4M's age-friendly care is what matters most. So honing in on what's most important to that individual and aligning care with what matters most. So that's a little bit about how we started the age-friendly initiative here at Mercy, how we're working to implement the 4M's. And like I said, this certainly is an initiative that is an opportunity for other acute care facilities, and also for outpatient practices. I also had the opportunity the other day to talk to a long-term care facility, in particular a memory care facility, that was seeking age-friendly health status as well. So a lot of interest becoming from many health care providers around age-friendly and the work that I had mentioned with the 4 M's. So if you are interested in learning more about the age-friendly IHI's work, I've listed their website there. So it's ihi.org /age-friendly, or you can even email the age-friendly folks at the IHI directly if you'd like more information. And so that is afhs@ihi.org. So I'm happy to take any questions. If you are interested in learning more about our journey, I'm happy to share that as well.
I'm going to take control back if that's okay.
Yes, that's perfect.
Okay, everyone, if anyone has any questions, please feel free to put them in the chat, or you can raise your hand or just reach out.
So I'd be interested, Melanie, if folks on the call have heard of age-friendly before, or the 4 M's.
I have. I do work with the Jewish Community Center. I table, and we've done a couple of events, and we're working towards actually having a pop-up clinic for our research program.
That's wonderful. So you've been exposed to the terminology around age-friendly and the 4 M's?
A little bit.
Yeah.
Still learning my way.
And there's so many, so there's also, so healthcare systems, obviously with the 4 M's, but in the community, we have some broader initiatives happening. So age-friendly Greater Pittsburgh, age-friendly, in general. And then there's also movements, and you may be familiar with this, working with the Jewish Healthcare Foundation, is the Dementia Friends, Dementia Friendly Pennsylvania, Dementia Friendly Greater Pittsburgh. I see Melanie shaking her head. Yeah, yeah. So, really honing, I think, in on how can we provide better, more holistic care, really, to, individuals, our older adults, but also our individuals living with dementia. So it gives us an opportunity to really think about integrating care from, kind of this lens of thinking that it really does take a team. It's not just, my background is nursing, but it's definitely not just nursing care, that it really takes that pharmacist, it takes the physical occupational therapy, it takes those care managers, it takes that physician. And really at the core, it really takes that patient to be open and honest and say, this is what matters most to me. Sometimes it's, things that we hear are like, I need to be discharged earlier because my son works shifts and that's the only time they can pick me up. And sometimes it's really those conversations that, unless you're really asking the individual what's most important, that could be missed in their care, and a missed opportunity for us to provide better care.
And that's kind of the premise behind the All of Us research program, that we were trying to accelerate research, improve health, working on precision and personalized medicine, making so that one size doesn't fit all. And I can tell you from a lot of our surveys with the hard data that we do, we have one survey that's on healthcare access and utilization. And, one of our big focuses also is to get as many people, the goal is 70% of the 1 million to be from underrepresented in research, and the elderly is one of those populations. And right now we're at 80% nationwide that of the people that we've enrolled. fit that bill. In fact, we've just surpassed the 500,000 mark, so we're about halfway to our goal. But there's a lot of questions there. The healthcare access and utilization asks about how your doctors may treat you. Are they open to listening to what it is that you want done? And I know my mom, who's 93, that she has a whole list when she goes in to see her doctors to ask them questions and make suggestions. She has no problem doing that. She still goes once a month to her book club meeting. She still drives herself everywhere. She still goes every Friday afternoon to get her hair done. But, not all doctors are like that. And I do a lot of telephone interviews with folks that don't have access to the internet to do these surveys. So I do them over the phone with them. And it's about 50-50, the number of people that will tell me somewhat horror stories about what it's like going to their doctors. So it's very important.
Absolutely. And, you said something, Mark, that just resonates with me, listening, right? And how important that is. And I think, for us that we found just asking that question, what matters most to you, as you look towards recovery here, while you're hospitalized, is an opportunity to open up that conversation and causes us to pause and really listen and think about the individual outside of their illness. So, one of the things that when I'm teaching staff is that I really hone in on person first language. So, it's not the demented patient, it's not the diabetic, in room whatever, it's the person with, so that we think about that person first. And so again, that's why I really like the 4Ms, because it is such a person focused, so individualized, way of providing care. Anyone else with experiences with the 4Ms or age friendly? Or has this kind of sparked a kind of I'm going to go Google that and find out more about age friendly and wonder, is that something my doctor's office is looking at?
I think the one question that I have is, before discharge, do they help those residents smoothly transition, getting them access, getting them connected to the Alzheimer's Foundation or, another organization that might be able to support them in their home environment, even home care?
Exactly. So, the one thing, so our, and I forgot to mention this, but our emergency department is one of the only emergency departments in the state to be at a level 2 geriatric certified emergency department. And one of the things that the staff does there is that they make follow-up phone calls. And that is a perfect opportunity, because when the patient's being discharged from the emergency department, if they're not being admitted, it's still kind of like a lot of information's getting thrown at you. But that is an opportunity that they take to make some of those connections with resources. And so UPMC also has what's called UPMC Senior Services, and they have a free help and referral line. And it's really like a kind of a one-stop shop. And so calling that help and referral line then gets you connected with a call manager that's able to provide phone numbers for the Alzheimer's Association, connect with, local support groups. And sometimes our patients aren't local to the Pittsburgh area. Thinking about being a trauma hospital, we get patients that are from outside of Allegheny County, sometimes, Ohio, West Virginia, places like that. And so what the beauty of the help and referral line is that, their individual is able to do those searches and make those connections with organizations that are even outside the greater Pittsburgh area. So yeah, and from those follow-up phone calls, we can, our ER staff is able to make those connections with the help and referral line, or even provide direct information to those resources. A lot of times we do, make those referrals to the Area Agency on Aging, obviously. And then also there are care managers. Our care management department has an overall goal of really providing those transitions. And so, even transitions to a skilled nursing facility and such, what might best suit the patient, and even looking at social determinants of health as well. So if somebody needs, having difficulty access to food, being able to make those connections. So yeah, lot of opportunity.
Well, thank you.
Yeah.
Hi, my name's Felicia Jose. I just chimed in. I just unfortunately, sorry, just got on the call now. I had other calls I was on. But one of the things I would like to relay, I'm not even sure what topic we're on, but one thing I would like to relay, I am going to put it in the chat. With PA Health and Wellness, we have what's called PHW Community Connect, and it's a part of the Find Help platform. And basically, if you go to our website with the Find Help platform, you can plug in a zip code and you can say you're looking for services for 5 or 10 miles or 20 miles, however, out, and it will pull up a whole area of help, from employment, from healthcare to transportation to household needs. It's very, it's very diverse. So that's one of the things that PA Health and Wellness we're doing to address social determinants of health and to make services more accessible. Even though we are a managed care plan dealing with elderly and disabled within the state of the Commonwealth, however, this platform, you can use it as the other lady just stated. If we have people that's outside of the state of PA, you can put in a zip code for Ohio, you can put in a zip code for New York or whatever area, and you will still be able to obtain resources. Because I know there's some agents that we work with that state that how they are working with other states, other counties outside of the Commonwealth. So this platform will allow you to do that. And like I said, I will put the link in there. Also, we from time to time have trainings around our website, the PHW Community Connect Find Help website. So also you can reach out to me to find out when we're going to have those next trainings. Thank you.
Oh, thank you, Felicia. That's excellent information. I think, anytime we can get resources easily, and that are sometimes broad, because I think with our older adults, even perhaps family members may be out of state and they're looking for information for their loved ones. So that's great.
Yes.
Thank you so much.
Yes. Yeah. Thank you for allowing me to share.
If you could put that link in, Felicia, that would be awesome. Does anybody else have any questions that they want to share? Or any curiosities that they want to share with anyone? Okay, well, thank you all for coming. This was recorded. We will be sharing this with everybody. If we leave the meeting and you have a question, please feel free to email us and we will make sure to get that over to Melissa. If no one has any other questions, thank you so much for coming today, Melissa. Thank you so much for presenting such amazing information. It's so great to see that we have these amazing supports for our seniors. If no one has any questions, thank you all for coming and have a great day.
Thank you. I guess I just made it in time, huh?
Thank you.
I would have got it anyway,
everyone.
Felicia, trust me, but thank you so much.
Okay.
Thank you, Melanie. Thank you for this platform. Thank you.
Yeah, sure. Everyone have a great day. Stay safe and healthy.